Good evening, and welcome to today's IAC webinar, Work-Related Musculoskeletal Disorders. How can we reduce the impact? My name is Marge Hutchison, and I'm the Director of Vascular Testing here at the IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar as we monitor those questions throughout the presentation, and we'll try to answer as many as possible during the QA period. Also, on the left side is the Resources tab. Click this tab for links to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look at the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the FSDMS CME credit, you must register, log into this webinar, then complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and SDMS. I'd like to now take a few minutes to introduce you to our presenter, Charlotte Henningsen. Charlotte Henningsen has many credentials, is currently an adjunct faculty at Advent Health University and a consultant for the American Institute of Ultrasound and Medicine. Ms. Henningsen has had a long and distinguished educational career. She has published numerous journal articles, textbook chapters, and has lectured extensively on a variety of ultrasound topics. Ms. Henningsen chaired a task force that developed the first national education curriculum for sonography. She has been recognized through receipt of the Society of Diagnostic Medical Sonographers Distinguished Educator Award in 2012 and the 2017 AIUM Distinguished Sonographer Award. She served as second vice president of AIUM and president of SDMS. She also recently completed her role as co-chair of the task force for the development of the WRMSD practice principles. With that said, I'll now turn the presentation over to our speaker, Charlotte Henningsen. Charlotte?
Thank you. And thank you everyone for being here. And thanks to the IAC and SDMS for the support and inviting me to speak on this really important topic. And thanks to all of you who are attending for your interest and contribution to reducing WRMSD in our profession. And I also want to acknowledge the work of the sonographers who've been publishing tirelessly on this important topic for many years, including the increased number of publications that we've seen recently in the past 2 years. Here are my disclosures. The objectives for this evening are to discuss the impact of work-related musculoskeletal disorders, WRMSD, to implement a collaborative approach to define mitigation strategies focused on reducing WRMSD, and describe ergonomic principles that reduce the physical and cognitive load. So what is WRMSD? Work-related musculoskeletal disorders in sonography affect muscles, joints, nerves, and tendons, and are attributed to repetitive movements, overexertion, fixed or constrained body positions and maneuvers with insufficient rest and recovery. These painful physical injuries may be paired with work-related cognitive stress, further exacerbating symptoms. WRMSD can lead to absenteeism and presenteeism and can also take an emotional toll. Rather than report injuries and seek solutions, many sonographers continue to scan in pain, and this can increase the severity of the injury that may not only impact work, but also impact normal activities of daily living and overall quality of life. As we look at the aspect of presenteeism, this is defined as continuing to come to work, but with a decrease in productivity. A reminder that when sonographers call out, their load frequently is added to the already full load of the sonographers present. The same is true, albeit to a lesser extent, for presenteeism. If the schedule is not adjusted to accommodate a decreased load, the remainder of the team may be expected to pick up the slack. Not only can that increase the scanning fatigue of the sonographers picking up the slack, it can also lead to retaliation to those who complain about being in pain, which can sometimes lead to a delay in sonographers reporting their symptoms. So there is a potential for both absenteeism and presenteeism leading to a physical and emotional toll on the symptomatic person and those that they work with. So let's look at the history of WRMSD and sonography and see what actions have had an impact on curtailing this disease. I do note that this is not an inclusive timeline. Craig reported WRMSD in the mid-80s, publishing Sonography, an occupational health hazard, in the Journal of Diagnostic Medical Sonography in the May issue of 1985. This research polled 100 sonographers with 5 to 20 years of ultrasound experience, and this article almost reads just like the WRMSD articles of today. A sonographer's shoulder was discussed in addition to what was titled, cable drag. Injuries needing surgical intervention were discussed, and a need to reduce work hours and having to change careers was mentioned. Among other problems, the article also explored vision issues, back issues, and stress and burnout. The first large study revealed 84% of sonographers scan in pain, and that was published in 1997 by Pike et al. WRMSDs were identified in Australia, England, Canada, Italy, Poland, in addition to many other countries. Following that, the first industry standards were published in 2003, and these standards were developed following consensus conference led by the FSDMS. In 2009, Evans, Roll, and Baker reported that in their study that 90% of sonographers scanned in pain. The FSDMS hosted another consensus conference in 2016, and a second industry standard was published. From both of these industry standards documents, we have seen great changes in equipment design, and yet we are still plagued with injury. The RDMS hosted a Grand Challenge Design Summit in 2019, and this Grand Challenge was forged through an alliance of multiple organizations, including the IAC and FSDMS, and SVU, ASE, AIUM, among others. The goal: to prevent work-related injuries, to stop WRMSD. The Grand Challenge goals are being met through an increased focus in part on WRMSD and injury prevention over the past few years. An example of contributions include the AIUM, who gathered a collaborative task force of representatives of other ultrasound-related orgs to develop the AIUM WRMSD practice principles, which were previously mentioned and published in the Journal of Ultrasound in Medicine in 2023. The alliance of organizations has supported and continues to support the ongoing research with a number of articles now in publication, some of which used for this presentation, including one just published in January 2024. There have also been several webinars from multiple organizations and increased focus in educational programs. And in 2023, Roll et al. Reported in a sample of 3,146 sonographers that 86% were regularly experiencing WRMSD that they attributed to their work. So it doesn't appear that we have been able to reduce the impact of WRMSD thus far. Do we know why? Well, WRMSDs in sonography are the result of repeated exposure to physical risk factors, largely attributed to sonographer scanning techniques. Individual movements alone aren't harmful, but frequent and prolonged repetition along with insufficient time for recovery can be risk-producing. The primary physical risks include force, pushing, pulling, lifting, gripping, downward pressure. Repetition, performing the same or similar task continually or frequently without adequate recovery time, performing the same exams repeatedly using similar muscle activity, and awkward or sustained postures of body parts away from their neutral positions, flexion and extension of the wrist, excess abduction of the shoulders, forward flexion of shoulders, reaching, bending, twisting at the waist, and bending or rotating the neck, and contact pressure, sustained contact between a body part and an external object, like resting the hip or the forearm against an exam table while scanning. I can remember anchoring the transducer cord with my hip against the gurney for many years to combat that cable drag. So as we look at these images, you can see rotating the neck, that abduction of the shoulder as we're reaching across the patient, or forward reaching, even as an educator is helping her students. So overall risk factors for musculoskeletal disorders also include pinch grips, and things more specific to sonography include that transducer pressure with that arm abduction, with twisting of the torso and neck, and sometimes all at the same time, and especially if we fail to take the time to adjust our monitor correctly. Research has also shown that lengthy exam times and/or a high volume of exams per day reported the highest levels of pain, with the highest injury rates found in cardiac, vascular, and OBGYN specialties due to the issues of lengthy exams. And you probably can think of some of the most lengthy exams that you are performing. And so here you'll see a wrist that is deviated. You'll see reaching from both arms, and then that sonographer hunch. We have a tendency to just hunch over to look at that transducer monitor when the hunching doesn't give us any more information than if we just sat up straight. And so as we look at pain and location of pain by specialty area, overall, I just want you to notice that in this research by Amanda Hogan, in part, they found that vascular had the greatest percentage of pain overall, albeit it was a close race and not a race that I would want to win. I also want to mention that visual discomfort and headache have also been frequently reported in sonographers as well. And then as you look at the location by specialty area, just note that again, the shoulder remains the #1 area for injury. Now, increased cognitive load has also been associated with WRMSD, and it's defined as the relative mental demand required for a specific task. Healthcare professions generally have high levels of complexity, thus increasing the cognitive load. Cognitive is derived from the word cognate, which means to think. And when we think, we are using our working memory, and our memory is not boundless. There is a cognitive capacity. That cognitive capacity relates to the amount of information the brain can process. And it will vary with additional demands and distractions at any given point in time. That intrinsic load is that which we would need to complete a task at hand, such as a carotid exam. And an extraneous load is unrelated to the actual task at hand, but it might be something such as, wow, my back is bothering me from doing all those exams I did yesterday, or I wonder what the cafeteria has for lunch. Cognitive distractions add mental stress beyond a task and task completion and increase overall fatigue, which includes muscle fatigue. And when muscle fatigue is increased, that increases the risk of injury. Other considerations regarding cognitive stress, especially as we apply work-related cognitive stress to sonography, are those environmental factors that add distraction to an examination that has a high level of complexity, thus increasing the cognitive load. Now, there's a paucity of research in sonography, but we can draw parallels from other areas of healthcare, such as nursing. The additional stresses which are most prevalent in the hospital setting can include portable exams with frequent interruptions, various people walking in and out, lights being turned on, beeping of alarms, meal delivery, environmental services, physician rounding, nurses giving meds, hallway noise, door knocking, TVs, mobile devices. These distractions can lead to a decrease in efficiency and the quality of our images. If it leads to failure to document adequately because something was forgotten in all of that chaos, then that could lead to a diagnostic error. Have you ever scanned a patient while the TV was blaring or while they were on the phone? We need to remind ourselves that it's okay to kindly let the patient know that we need to turn off the TV and have them set their phones aside, and their visitors in the room, their phones aside as well during the exam, so that you can concentrate and give them the best exam possible. Think about areas where you've gone portable and have virtually no control over the environment. Or do you scan in an environment where everyone is welcome to come into the room? All of this can lead to scanning fatigue. PT, OT, respiratory therapists, X-ray, social workers, chaplains, patient visitors, including children, intercoms, questions about the exam from physicians, patients, visitors. You may have other examples from the environment where you work or have worked in the past. Certainly, these stressors are most prevalent when we are portable, but consider these cognitive stressors that are in your departments as well. In addition, cognitive stress can be further increased if you're dealing with other personal life issues that add to your extrinsic load. With all these distractions, how are we in a mindset to even think about ergonomics? But we must. Consider your scanning space overall. Do you have dedicated imaging room with a sink and space for other supplies that you need? You should have room for the machine, the scanning table, the chair or stool, and any additional people who may need to accompany that patient. You want enough room to be able to adjust that space without a lot of difficult maneuvering. Can you switch the bed or machine around easily? Even if you do primarily one type of exam, you still have patients of different sizes with variable mobility considerations, and that means you will likely need to make some adjustments for each patient you scan throughout the day if you give proper attention to ergonomics. And don't forget the ancillary materials: gel, linen, support cushions, You want them close by as well, so you're not reaching for those. As we consider the basics, we should maintain shoulder abduction of less than 30 degrees, or use a bolster or roll towel if you have to reach beyond that and need that support. Keep the elbow bent at approximately 90 degrees. The bed, the machine, the chair, which includes the sonographer, as close together as possible with the height adjusted, including the monitor, which doesn't always need to be adjusted along with everything, but may need to be adjusted separately for individual scanning. Remember that a monitor that's positioned between, just a little bit between the machine and the bed, allows for a more neutral position of the head. The patient should be as close to the edge of the bed, as close to you as possible. And ask the patient to move and let them position themselves as much as possible. We want to avoid moving patients unless absolutely necessary. And make sure to adjust the lighting, and the computer workstation needs equal attention and adjustability to avoid risk of injury. Some good scanning practices include varying standing and sitting. And I want to acknowledge that depending on your stature and the equipment that you have, you may find that this is not possible. I worked in a place where the bed didn't go up and down and the stool didn't go up far enough. And so I had to stand, and that was fine because I could get in the best ergonomic position by standing for my exams. But if you have the choice and can vary, then that's best. And vary exam types if possible. And it's best if the schedule can be set up that way. Switch scanning hand. And I know that can be challenging. A lot of sonographers in our environment do echo and vascular in the same department, and a lot of them scan their echoes left-handed and their vascular right-handed, and so they're using different muscle load and giving different hands a break throughout the day. Is there something that you can do where you can vary exam types, which will vary the muscle load that you are using? Also, can you use a cable brace? We can reduce some muscle load by wearing a cable brace, and that reduces that cable drag, which can really be a drag. Also, you should avoid putting the cord around your neck, as that creates torque on the neck. And take schedule breaks. In an 8-hour day, you should have a minimum of a 15-minute break in the morning, a 15-minute break in the afternoon, and a minimum of a 30-minute meal break. And also take micro breaks. If you've frozen the image, take the opportunity to lift your hand and relax your grip. A micro breaks of 3 to 5 seconds have been shown to reduce scanning fatigue, but that does not take the place of taking those longer actual scanning breaks. And so I want you to look at these two images, because this gentleman is varying sitting and standing, but when you stand, you have to make those ergonomic adjustments so you can stand up straight, or you're not doing yourself any good. In addition to micro breaks and cable brace, keep a neutral wrist. Keep flexion and extension to a minimum, and avoid awkward sustained deviations to the right or to the left. The transducer should be positioned deep in your palm with your fingers, not your fingertips, on the transducer. This is termed a power grip or a palmar grip. Especially for new sonographers who sometimes have that death grip on the transducer, try to use as light a grip as possible. If your hand is cramping, your grip is too tight. Use minimal pressure necessary to acquire the images. Position your hand low on the transducer for needed fine motor control rather than putting fingers out on the patient. And also, we need to minimize those portable exams. They should be limited to those patients who truly cannot come to the sonography department, as it can be quite difficult to practice ergonomic principles in a portable environment. And just a reminder that if inpatients come down in wheelchairs who need significant assistance to maneuver from the scan bed to a chair and vice versa, this is adding to the sonographer's risk for injury. Sonography departments can be relatively small and can lack the manpower and tools to safely assist patients from bed to chair. Sonographer safety and patient safety should be considered and prioritized, and those patients should come down on gurneys or stretchers. And then what about what's termed concierge service or boutique service? Patients may not feel like leaving their room, and so a portable is ordered instead. Or have you seen where there's a dedicated machine for all inpatients to avoid using that room in the department? These are both practices that greatly increase the risk for WRMSD. And we want to avoid reaching. As we try to avoid reaching, we want to have the patient scoot as close to us as possible. For instance, if you're scanning legs, you could move the bed or the machine and scan with the alternate hand, and that would give rest to one of your hands. And hopefully one of those, the machine or the bed, isn't too heavy and you have the space to manipulate it easily. That gives you the rest of one hand in the middle of what might be a lengthy exam. If you want to scan the entire exam with the same hand, then you can have the patient sit up and twist around and then lay back down where their head is where their feet were. Now you'll need to make some additional adjustment by moving the pillow and covering the foot of the bed with a clean sheet. If you've never tried this, I hope that this can be a new technique to try if the patient is able to assist you. So here you can see the sonographer scanning the right leg, and the patient turned themselves around, and now they're scanning the left leg, and they're scanning both with their right hand. Whoops, sorry. There's some things that we as sonographers can directly control and things that follow under the purview of administration. We can all do our part in seeking ergonomic training. The industry standards, as well as other guidelines, support a minimum of annual education. And as we look at those things that fall under administrative control, breaks, including lunch breaks, should not be considered a luxury. And if the schedule can be set to allow for task rotation, it makes it easier for sonographers to rotate exam types. You may or may not have ergonomic equipment, and it's equally important to have the space to use the ergonomic equipment that you have as efficiently and effectively as possible. Long shifts do not allow for appropriate muscle recovery, and I know this can be unpopular, but research shows that reducing shift work reduces the risk of injury. Portable exams also should, again, only be for those patients where it is truly necessary. For those who are medical directors, administrators, directors, and managers, we need your help. We are too quick just to squeeze in one more patient, missing a break, missing part of our lunch or an entire lunch because we think we're helping the patient. Help sonographers hold themselves accountable by engaging them in conversation and developing departmental policies and procedures in writing that will help reduce the impact of WRMSD. Let us remember that we will be distracted if we're scanning in pain. We need to embrace good ergonomics as part of our job. Good personal health also includes good nutrition and regular exercise and appropriate sleep. When we work to decrease the risk of WRMSD, we not only help ourselves, we better serve our patients. So this is shared responsibility as we develop these quality improvement plans. Remember, this includes all that's being done by sonographers, sonography educators, students as they begin their new careers, employers, manufacturers, accrediting and certifying organizations and associations. Education is important, but alone it has not reduced the impact of WRMSD. Fukumura et al. Elucidated that training and equipment alone are insufficient to effect change also. So education and the use of ergonomic equipment is not enough to reduce the impact of WRMSDs. Work practices and procedures should be evaluated to look at scheduling and at breaks. Roll et al. Identified these factors that can be addressed by organizations and help establish a culture of safety in the workplace. When employees and employers participate in safety, advocacy, and solutions, then engagement occurs across all levels and can be more effective than a top-down approach alone. Collaboration is an important key to identification and implementation of evidence-based solutions to improve the safety and health of sonographers. Decreasing workflow interruptions is a critical piece of reducing the impact of WRMSD. Interruptions to workflow timing and pacing was the most frequent factor significantly associated with experiencing all three types of work-related symptoms: pain, headache, and visual disturbances. So what are these workflow interruptions? They may be exam or procedural difficulties, such as that high BMI or problems with the machine, administrative roadblocks, physician orders, problems with insurance, or late patients. These types of disruptions were found to occur in about 50% of the time in a standard work week. And these stressors increase the chances of experiencing MSK pain, headaches, and eye strain. WRMSD is impacted by performing the actual exam and also by the workflow that is not directly part of the exam, and the challenge is finding solutions to improve or manage these processes. And working on it collaboratively provides an opportunity to create and or improve the workplace culture. It's important to cultivate a culture where symptoms can be reported without fear of retaliation. Can this help reduce the impact of WRMSD? I think it can. My challenge to you is to make ergonomic education fun and interactive. Create a journal club, maybe with CME. Get in a room and demonstrate and practice good ergonomics. Start each exam with a quick ergo self-check. Create a poster to remind you what good practices are and switch them out. I made this slide based off an article that was specific to shoulder injury prevention. Talk about workflow interruptions and discuss solutions that will affect your department in a positive way. And remember how the cognitive stress plays a part in all of this. So in conclusion, we want to embrace ergonomic training. It should be for all new hires as part of their orientation so that they will know this is an expectation for them. It's an expectation of the department. It's important to everyone in the department. and that this is going to be something they're going to be regularly engaging in. And then a minimum of annual education for everyone. Adjustable equipment is only useful if we use it. Develop written ergonomic policies and procedures and collaborate on those policies and possible solutions, and consider how cognitive stress might be reduced. And one small step might be as simple as hanging a do not disturb sign that should be placed on any door when an exam is being performed. Discuss if misuse of portables needs to be addressed in your department, and work with your advocates in your department and beyond to help develop policies around misuse of portables. Remember that adequate breaks are critical for muscle rest and recovery. We should all support the ability to report pain without fear of retaliation, and collaborate on finding solutions to decrease workflow interruptions. I've listed several references at the end of this presentation that you might find interesting and useful if you want to take the lead in your department. There are lots of resources available to you today to help you on your journey. So let's all do our part to reduce the impact of WRMSD. Here are my list of references, and I thank you all for your attention and for being here.
Thank you, Charlotte. So at this time, we're going to begin our Q&A session. I'm Katie Gibson. I'm the Director of Accreditation for the Division of Echocardiography at IAC. And I'm also going to have Marge step in and help rapid fire some questions at you, Charlotte. So we're going to start off with a question about rest time. What is a reasonable rest time in between each patient?
There have been some studies, and it's not definitely as necessarily as prescriptive as we may like it to be. I think what's most important is that we adhere to having those breaks, those full breaks. But I do know that there is some research, and this is research, where they were taking like 5 minutes of rest and recovery between every patient. But you need to remember that when you are resting, that means that you're not filing, you're not writing up a report, because that still is using your arms, and you need your arms to be in that rest recovery phase. And so there are so many places that don't even have break policies, just minimum number of breaks. If we can start with that, I think that's probably the most important thing, because we know even just what the workforce policies are regarding breaks and regarding lunch breaks, and we need to make certain that we're at least adhering to those.
I'm going to hit you up with a follow-up question about that before Marge jumps in. How would you talk to your administration, or even just the office manager who creates the schedule, about creating breaks within the schedule? What suggestions do you have? Because that can be a little difficult for a sonographer to advocate for themselves at times.
And I have encountered that issue actually with a friend of mine who's chatted with me about it. And one of the things is, and she's in a small department, and she advocates, and I've had other sonographers at meetings when we've talked about WRMSD tell me the same thing. They may be wanting to be able to take these breaks, but some of the other people in the department will be questioning, well, why do you need these breaks? Mm-hmm. Well, the break is for prevention. It's not for, after you're in injury. The purpose is let's not get injured. And so I think that part of it is doing your homework and taking the literature. This is what the literature says. And when we have, when we're not moving our needle and we still have almost 90% of sonographers getting injured and scanning in pain, I mean, that number alone is just shameful. And we need that rest and recovery time. And there's enough literature now where we can talk about that and we can take the evidence with us. And so we can't deny that. And if you're not having pain, then hallelujah. But, it's not about getting rid of your pain. It is about not having pain because you're doing the appropriate things so that you don't develop WRMSD. And so I think that if you can gain the advocacy of your team, gain the advocacy of your medical director, if you have a medical director, or the physicians who are working with you, a lot of times that can also be helpful because they will understand, that if they're scanning at all, they know how that can impact someone's work, and they probably will see you in pain and know that it needs. And if you wind up going out on injury, there's also data to show how expensive that is if they have to pay for someone to fill in, if they have to pay workers' comp. All of these things are very expensive. And much more than if you just go in prevention mode. And that's the whole key is prevention mode, not trying to reduce what's already happened, even though we want to do that too, because we are there, but we want to prevent injury for those who are coming up, who have grown up with this information, and now we just need to use it.
Thank you. We've definitely given us lots of reference material to go through. So.
Well, that's the $1 million question. We've talked about it. We always talk about this is numbers of studies a day and time limits and all that kind of thing. The problem is, as I'm sure everybody knows, is there's a sonographer shortage. And so, I mean, we know there's problems, but how do we address them when we have other problems?
And so, one of the things that I think would be very inviting, if you have been a sonographer and you have worked in the workforce and you have worked where were not good breaks, there was not a good WRMSD prevention plan, how nice for an employer to be able to put that in their toolbox when they're hiring. And by the way, this is part of our plan for you as a new hire. And that would be so refreshing, because I don't hear of a lot of places. And those of you who are on this webinar tonight, if you have those, then that is a great thing, because there's so many people who don't have those. And so from an employer standpoint, if you can develop those plans, you can use that as a tool to get those sonographers to want to work for you, because you care about their bodies and you care about injury prevention. But it's not the whole issue of scan times. It's not black and white, because the scans vary based on the patients and their body habitus and their particular situation, but they also vary greatly on the length of exam time. And so there's so many variables that it makes it very difficult to really pin down scan times. I did read one research article where they looked at their facility and they did research and they tracked their exams and how long it took. And they looked at from the time the patient was brought back to the time that they dismissed the patient, and then the scans. And so they had a log of the different exams and how much time each of those took in total. And so if you are working in a facility and you're struggling with that exam time, issue if somebody's willing to take the lead and say, why don't we start tracking this? And you could create a plan for your department based on, you know, what you do in your department, because it's so variable across. It's really hard to have just one quick fix, quick answer to that question.
Thank you.
Yeah. Do you have any idea or theory on why sonographers resist daily stretching or exercises, which could potentially help prevent injury?
Well, probably the same reason that I see that some sonographers risk their having annual education in WRMSD. It's like, well, you know, I'm not scanning in pain, so why do I need to do this? But again, we really need to focus on prevention, and I just think that we need to change the culture, because the culture up to now has been trying to address all the injuries. And so now that we know that some of these things like the workflow interruptions, and we know how much the cognitive stress and cognitive load can add, and that can vary greatly in a department, then, you know, we really need to focus on prevention and not wait till you're injured to deal with it. I know a department that had 3 sonographers go out within a year for shoulder surgery. That was very difficult for that department, you know, because they were always missing someone.
Yes. So there's just so many questions here. I just want to say that if we don't get to your question tonight, we will answer them by email in about a week or so. So don't think we're ignoring your question. You know, a lot of people are saying, you know, this has been an ongoing problem, you know, for years now. And are we seeing decreased injury, or are we seeing decreased reporting of the injuries?
Well, from the 2023 research that was done, which was a pretty big sample size, you know, 86% scanning and pain, that's not really a significant decrease in the injury rate compared to the 90% that we had seen previously. And so I don't think that we are seeing a decrease in the injury rate. I think that we are, the research that has been going on is identifying some variables that may have not been looked at before. I think that originally we thought, well, we just need education. A lot of people weren't getting education in a WRMSD, and now we see it's over 70% of sonographers report that they are receiving education. And then, you know, it was, well, we need ergonomic equipment. And then we saw more people were getting ergonomic equipment. But, you know, if they're stretched for time, they don't always use it. But even then, you still have these workflow interruptions that add to that cognitive stress and that cognitive load. And so, you know, I don't want to compare us to any specific profession, healthcare profession. But I think that one of the things that I have thought about is the fact that for years we thought ultrasound is safe, you know, and so it's like everybody was invited in the room, and all of those things were adding to our cognitive stress, which we didn't understand, because we felt like everybody should come into the room because it was safe you know, it was safe. It was a safe procedure. And so I think that there has been a shift in that, recognizing that, yes, this is still a complex exam, especially because ultrasound is so operator dependent. And I'm preaching to the choir here, but, you know, we all know how operator dependent it is, and it does require a modicum of concentration to be able to perform correctly. And I think that that there still is that mindset. If there's doing a sonogram, it's like, oh, they're just doing a sonogram in that room, you can go on in. And we need to change that mindset. That's why I think that even if, we're portable, if we can stick a sign on that door, if we can engage in our institutions to say, sonographers doing an exam, it's just as important that they have that uninterrupted time as if a physician was in the exam, in the patient room doing a sensitive exam. No, you wouldn't dare walk in then. And so, we just need to change that mindset where they realize that even though it is safe for the patient, all those distractions can actually impact our patient ultimately when we get distracted.
Yeah, and you're getting compliments about that in the questions for bringing that up about the interruptions. And I was going to ask if you had any other suggestions on how to reduce the interruptions. I love the suggestion of taking a sign, with you portably or bringing them down to the room. So I just wanted to bring that up. People love that you've brought that up because it is it's very important.
Well, I've had that happen, for me personally. I have worked in the point of care arena, and, in the emergency room, when I talked about, the PTs and the OTs and everybody's coming in, all of that has happened. I've had somebody come in to start an IV, and literally they expect me to stop what I'm doing and move so that they can get their IV started. And talk about losing your concentration. It's like, where was I? What did I document here?
Well, I think you also bring up a good point for the patient's sake too. I mean, that's, like you said, they may be in a position where they didn't want that part of their body shown to everybody who's walking in the room to give them meds or so just kind of trying to change the mindset of the whole team. It's very important. You kind of talked about venous and switching up legs, but other modalities may need to switch sides of the room too. So do you have suggestions for if you were having trouble scanning comfortably when scanning, say, the left breast versus the right breast, or even OB patients when the baby is all the way on the other side, fetal echo? Do you have some suggestions for how to effectively employ your ergonomic safety things when scanning the opposite side of the patient?
So certainly one important thing is rolling the patient up towards you, and that where you can. And that is something you can even do, with an OB patient is have them roll up towards you, and then you can scan that other side. But the minute you do that, I mean, I did OB for a number of years, then the fetus is going to move, but that might be to your benefit also. Yeah. It's not a one and done. There's not one thing to look at. It's every patient you're going to have to consider. Is this patient really all the way to the edge? Can I get them to slide over just a little bit more? And now I'm not really reaching as much. Or I even have found that I always found my wrist was so awkward when I was doing thyroid exams. If the patient was very large breasted, and now I do those exams standing, because then my arm is not really wrapped around their chest area. And even though I would lay a towel across them and get permission and tell them why I was reaching that way, it just made so much more sense. Or doing it from the head of the bed like you do from a carotid. Yeah. And you can do either of those things. I've had sonographers tell me, I set up a room for left-handed scanning every other month. And they use that and keep their left-handed scanning skills. And they did that because they had an injury. And so they had to learn to scan left-handed, and they don't want to lose that. And so I think as much as we can force ourselves, I'm very fortunate. For one, I'm left-handed. And when I would go portables, if I could, I would always do them left-handed so that I was really using both arms. And I think that if we can use both hands, then that can be very useful when we're scanning. You know, and again, it also depends on your particular machine and your bed and how easy it is to manipulate all of those. And the other thing is how mobile your patient is. You know, when I showed the switching of the legs, you're not going to want to do that if you have to help the patient up and down and to switch around, because then you've added again to your pushing and pulling a lot more. But when you have patients who can help you with that, then that can be very helpful. And so even you know, I always look at things like a kidney, you know, with the kidney exam, you can scan the right side sitting, and then I'd stand up and roll the patient up on their side, and I would scan them from the coronal plane standing. And with very few adjustments, because when they roll up, then that body part is a lot higher. And so a lot of it is really looking at your particular circumstance, but also listening to your body. Is this feel okay? And then as you look more and more, like this one article that was just specific to sonography reducing shoulder injury, you know, if we can find more of these articles, and there are articles out there that show scanning, ergonomic scanning, that are more exam specific. And again, that still is not going to answer all the questions, but the more we can look at those types of things, but also be creative and get and again, get in a room with someone. Look at how I'm scanning. Does this look awkward? What am I doing wrong? Because sometimes you don't realize that you have developed these bad habits. And I think the more that we can collaborate with each other. Another thing that we have done is occupational therapists are great at helping when you're in awkward positions and helping find ergonomic positions that are, and we've been able to tap into that at our institution. So you may be able to do that as well, depending on where you work. And so, you know, when we talk about it takes a village, it really does take a village. And talking to your physicians when they go to ultrasound conferences, you know, if they're getting information, bring back the ergonomic information, or did you see a new technique and how were they doing this? Because we've all got to learn from each other, and we can't be proud about it. I mean, I grab all the information I can from everyone so that you know, I can make certain that I am being as safe as I can for myself, and so that I can help share that with others.
Thank you so much for that. This has been a great Q&A session. Lots and lots of great references. You know, don't forget to print out the PDF of the slides, because all those references are golden. I definitely want to thank you, Charlotte, for this presentation today. It's been, I always learn something new when I attend the work-related musculoskeletal disorder sessions, and surprising myself with that. So everyone else, please feel free to contact IAC if you have any questions that were not answered during this session. Just as a reminder, to receive continuing education credit for attending this webinar, please complete the survey. The link to the survey will appear on your screen automatically at the conclusion of the live session, and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars. Look for the title of this session, which is Work-Related Musculoskeletal Disorders, How Can We Reduce the Impact? Beneath this title, you will click Review Event. On the left, select the Evaluations tab, then click Take Evaluation to complete the survey. Your certificate is then going to be emailed to you directly from FSDMS after processing within 3 weeks. If you have any questions about the survey, please contact us at webinars@intrasocietal.org. And once again, we thank you for joining us today and appreciate your participation. Have a good evening.